Now we're moving on to the next talk, and Dr. Iorio is going to take it over about how not to be misled by the literature.
Thank you. Okay, so good morning everyone again. I repeat you the message that I gave you yesterday because it's a good introduction to this talk. The true learning happens in the tutorials. Happen in the tutorials provided you had at least glimpse at the articles before. I know that is difficult to find time to prepare for the tutorials, but believe me, if you get 20 minutes to go over each of the articles we are going to use in the tutorials, you will gain much more because you will not need to focus on where this information is, or you will be quicker in retrieving that information, and you will focus on the content. And what you have through the frontal lecture, the one that Yasmin gave a second ago, most of the questions she asked you were covered yesterday during the tutorial. So I'm sure you didn't answer because you are shy, even if it's tough not to answer when someone so nice and charming asks you a question, but still, you didn't. Now, as you have experienced yesterday, I'm not as sweet. I will ask you a question again, and you have to answer. If not, we spend the rest of our life here. But focus on learning on the tutorial. These lectures are really meant to let you refocus, fix concept, and see why those concepts are important. Now we will be covering some studies where things didn't go well. Now you have seen that the one we focused on yesterday, both in the treatment arm, in the treatment tutorial and in the arm tutorial, they were pretty good studies. They had limitation, but overall they were good. And that's why they were chosen, because they were good material for teaching. Now we'll see some studies that instead are the one you would need to pick up as not so well done. And my last introductory remark is that studies are like patients. First time you see a patient, I wouldn't say that someone has to teach you where the head and where are the feet. That's something that you should know by heart, even if sometimes you wonder if staff didn't see patient for long enough not to recall anymore which side they lie in a bed. It happened to me when I was a resident. But anyways, you should have the experience that the more patient you see, the faster you are recognizing those that require your immediate attention, particularly when you rotate in emergency or in ICU. You develop that sense, that clinical expertise that let you focus on what require immediate attention. And you don't need someone to tell you. Okay, if there is a triage code that helps, yellow, white, green, or red, but you can guess yourself. The same is with studies. If you don't read them, you have no clue. So I wouldn't say you have to read a lot, but if your goal is in the end to keep up by reading literature, do that constantly over time, one per week, one every 2 weeks. Take 15 minutes. Register to an alerting system, get good literature, but read. If not, you will never be able to pick up the mistakes I'm going to show today. So we will be focusing on some aspect, 6, if I can stay in time, if not 5, and we'll skip the last one. Even because confounding in observational trials, we have been focusing on yesterday. Yasmin helped us with the coffee example, and Fahad pointed out the most common and powerful solution. So if I had to skip confounding, would not be a great loss. On the other hand, if I can get there, would be a good repetition, and I'm sure that it will be helping fixing concept. But these are the topics I'm going to cover. Speaking of conflict of interest, this is my unit. besides me is Brian Haynes, and then the readers, the indexer, the librarians, and the IT people in the backend. This is the unit that is behind the MacPlus database, American College of Physicians Journal Club. Now we are collaborating pretty closely with Dynamed to provide them with evidence to keep Dynamed up to date. Now, conflict of interest. Let's look at the result of these myth analysis. You know now that I like systematic review as myth analysis, so no surprise. We'll start again with the myth analysis. And this one was done now 15 years ago by the Nordic Cochrane Center in Copenhagen to investigate if funding sources had any effect on trial conduct. And they selected 167 Cochrane reviews randomly out of a sample of 1,000. In 2001, the Cochrane collaboration had about 1,000 reviews. Now there are over 5,000. We will read one in the tutorial later on systematic review. So if you don't know what the Cochrane collaboration is, you will learn today. And then out of those 167 they sampled, they had to exclude some because they wanted reviews with at least 10 studies, and some others, and 100 were excluded because they had less than 5, and then others were excluded for different reasons. They ended with 25 reviews, including in all 370 randomized controlled trials. And they took out of those trials sources of funding, effect size for primary outcome, how big of an effect the trial was showing, adverse effect, and methodological quality. They scored each of the study for the conclusion. This is a scale they created and used, and overall they scored 6 the studies that were concluding strongly in favor of the intervention. Drug A will change the world. And they were scored 1 studies saying, don't bother about drug A, placebo is saving the world, or the comparator is saving the world, okay? So they scored the relevance, the strength, sorry, of the conclusion from very low, 1, placebo is better, to 6, the intervention is much better. And here are the results. So first of all, and I'm pretty sure you know, about half of the studies were funded by for-profit organizations. You know, Cochrane people is extremely averse to any relationship with industries. And they can't even write here pharma, but that's pharma. I mean, you can say non-for-profit organization and for-profit organization who think can sponsor study on drugs, pharma. So you may say for-profit, but it's for sure this is pharma. So 1/50 of the study, about half, were sponsored by pharma, which is normal. They produce drug, they do research to discover new one, and they fund studies trying to show that they work. So nothing wrong there. Problem is that the studies done by sponsored by for-profit organization had an average score of 6, so they were commonly concluding in favor, and the number of trials scoring 6 was 74, which is about half. If you look at, for example, studies by non-for-profit organization, so NIH, CIHR, public funders, the mean score was 4, and only about 1/6 was scoring more than 6. So out of this first look at the data, it seems that it's more likely for sponsored study to show an effect. And when the source was not clear, the effect was mixed. So there is a sort of a gradient, 4, 6. When you are in a mixed situation, you are in a mixed level of conclusion in favor. Now, they went on and they analyzed the predictors of a strong recommendation. And of course, bigger effect size. The bigger the effect, the more life saved, the more stroke spared, and so on, the stronger the recommendation. Does it make sense? What do you think? Would you give a stronger recommendation for a drug for which there's a larger effect? I would. Okay, so that makes sense. Blinding. You have learned yesterday about blinding. Would you trust better a study which is blinded? Yes. So again, makes sense. For-profit funding. Again, well, would you believe it? I believe it. I mean, it's in the data. But would this make sense to you? A for-profit study. Why you would give a stronger recommendation or give more credibility to a study that is sponsored by pharma? Do you have any good reason to do that? No. These are all studies, so one may conclude published studies warrant a strong endorsement. And for-profit studies, really, they show larger effect. And why they show larger effect? Well, one reason is that they have more money and they do a study better. Doing a large, randomized, double-blind, double-dummy study costs money. And pharma has more money. So it might be that really the only reason why it seems that sponsored studies are better is because they are better done. So they get larger effect just because they are better done. Could it be? So being for-profit is not really the reason why the recommendation is stronger, it's a confounder. The reason why the recommendation is stronger is that the study is better done and show a larger effect. That's an hypothesis. The alternative hypothesis is that since they are going to sell the drug, they make the effect appear larger. And that's why we are a bit cautious in saying, oh, okay, I believe it. Of course, if you don't believe it, though, you have to stop believing that everything that is published is good. Yasemin was saying before, many people like study published on New England. I don't personally, and I think I told you yesterday during the tutorial that New England is the journal with the highest number of retraction for false or misleading result. 13% of studies published on New England get retracted in 3 months. And the trick is in 3 months, whoever is putting the study up there makes enough money and gets enough drive that doesn't matter the retraction. No one will notice the retraction unless it's really a mess and people is dying like hell, in which case, of course, they end in jail. But if not, being up there for 3 months is enough. And you don't know, if you are not very careful, that studies are retracted. So you may say, I don't really believe that pharma studies are better. I think they are massaging the result. But then you have to stop believing that whatever is published is good, because those studies, they made it to publication. So peer review may not be perfect. What's the solution? Well, the solution, again, is stratification. So you start dividing the studies in those showing a large effect, high quality, small effect, high quality, large effect, low quality, etc. And you analyze how the for-profit do against the others within each stratum. So instead of saying, I don't know if it's being for-profit or being showing a large effect, start doing strata. You know that strata is a way for us of understanding multivariable analysis. If you do multivariable analysis and you consider non-for-profit as the reference, you see clearly that the strongest predictor of strong recommendation is the independent predictor. So this means after adjusting for treatment effect. By the way, treatment effect is not a predictor. It gets in the other direction. So the strong recommendation for or against does not depend on the treatment effect, depend on double blinding, is 3 times more likely to have a strong recommendation if the study is blinded, but is 5 times more likely if the study is for profit, no matter the other characteristics. So first thing you'll check in a paper, and I would say even before the methods, you go to the very bottom, before the references, where the conflict of interest and the sponsoring is acknowledged. If every one of the authors got money from the company who's making the drug, and the drug paid for the study, not saying that is necessarily bad, but is 5 times more likely that the results are showing a significant effect. So read methods and result and check the funding source and the conflict of interest. And skip the discussion. Because the most common way that studies are biased is not by falsifying the numbers. The numbers are correct. So if you read what they did, and if you look at the result, you can come up with your own idea, provided you have attended this course. If one time is not enough, I don't know if you are allowed, you'll take it a second time, or you continue reading. There are resources you can use. If you get your own critical capacity to read through the method and the result and understand what they did, you'll see that in many of these studies, you can't link the conclusion with the result. The result shows something, and the conclusion suggests something which is different. We do this job for the American College of Physicians. We rewrite the conclusion of studies based on our reading, and they pay us money for that. And we send out every morning 20 or 30 tweets to American physicians with our interpretation of studies. At some point, we stopped because they decided that they didn't want that anymore. And in a week, the ACP got tens of thousands of emails asking why we are not receiving anymore that line. Because they were used to see that many studies, they had different conclusions in the abstract as compared to what would be reading the results. So if the study is pharma-sponsored, I know that you really like reading discussion of studies, and I know that you can't sleep well if you don't read at least one study discussion per day. Skip it. If it's a pharma-sponsor, you don't care what they say in the discussion. Skip it. Just look at how many people got and not the events, how many people got and not the side effect, and decide based on that. The discussion very often is completely unrelated to the result. And they say, you know, we make this drug, why don't you use it? And why don't you recognize it's better than anyone else? Then if you look at the data, that's not the case. Sometimes, since really falsifying the number is really bad, you end in jail if you do, or you'll have then trouble publishing again. You can't really reverse the number and then say, oh, well, I'm sorry, I was wrong. But you can do intentional mistakes in planning the study. You can build the study for success. John Ioannidis, who was part of the Cochrane collaboration and is one of the most published contemporary authors after Gordon Guyatt, Salim Yusuf. If you look at highest impact factor, John Ioannidis is there. He's Greek, as you can guess from the name, from Thessaloniki. He has still a research group working there, but is now at Stanford. And he's spending his time now going around and saying that the best way to support ineffective medication is through EBM and through randomized controlled trial. The EBM and randomized controlled trial were introduced initially as a way of finding out what works and what doesn't, and do good science. Now, it's true, but you have to be aware how to read a randomized trial. And if you think of someone knowing well how a trial is done and will be read, you can make it up intentionally in a way to show whatever you want. And the methodology is perfect. There are other gross mistakes that make that trial to be falsely true, to support what you want to show. One way is choosing a wrong comparator. So, or use a placebo when the comparator is not what you want to compare to. Now, yesterday, at least in my treatment group, we made the point, or I think was during a lecture, I don't recall, made the point that you have to have a comparison with placebo, because you have to be sure that a treatment is active. The only way is to compare to nothing to show that it's active. Because if you compare to a non-effective drug, you can show equivalence, but equivalence to non-effective means ineffective. So you need to have at least a few trials against placebo. But then what is needed for clinical practice is the comparison against an active treatment, usually the standard of care. So is there anyone here who manages patients with diabetes? Okay. So there are a few diabetologists. Some raise the hand very high, some other just a bit, but in general there are diabetologists. Good. So what would you give to prevent the kidney of your patients? ACE inhibitors. Good. Do you agree? ACE inhibitors. Anyone would give something different? Okay, angiotensin receptor blockers. Good. And indeed, when they came up, they were proposed as the best treatment for preventing diabetic retinopathy. And you would expect that they were compared with ACE inhibitors. ACE inhibitors were there before. Do you recall what was the reason to look for alternatives besides making money? Coffee. So ACE inhibitor is a very good medication, save the kidney, in a proportion of patients which is sizable, gives cough. And there's nothing you can do. You have to stop the medication. If not, the patient can't speak anymore, he just cough. It doesn't go away. So they were looking for another way of getting the same effect. The receptor is downstream in the same pathway without giving cough. So that was the main reason. Now, if you take the pharma perspective, it's good to have a drug for someone with a side effect, but it can get maximum 10%, 7–10% of the market. You have to try an ACE inhibitor first. If you have cough, you go to the ARB. So they were trying to show that ARB was not only avoiding cough, but doing better. But notwithstanding, there was a strong evidence that ACE inhibitors were preventing kidney function, and you know, and you use them. They decided not to do studies against ACE inhibitor, but they mostly did studies against placebo. I told you yesterday that a way around the absence of head-to-head comparison is to use network meta-analysis. Now you are expert in network meta-analysis, and you know that you recognize it because they have a figure like this. No, it's not clearly a forest plot. So you can distinguish a standard meta-analysis, they have a forest plot. And a network meta-analysis is something like this to start with. Then there are forest plots. So you see, the bigger the circle, the more patients. So a lot of patients on ACE inhibitor compared with a lot of patients on placebo, less patients on ARB, mostly compared with placebo. The thickness of the line shows how many patients were across. So a lot here against placebo, a lot here against placebo, a few compared directly. And then many other treatments. They took all the treatments available and used, and they started looking at the direct and indirect comparison. The result, or they did it, for mortality and for end-stage kidney disease, which is what we want to prevent. So 4 studies directly comparing ACE and placebo, 3 comparing ARB and placebo, 2 comparing ARB and ACE, and then indirect comparisons. The way the result of a network meta-analysis are presented is varied. There are tables, vectors, and forest plot. I'm showing you forest plot. Now, in this forest plot, if you look for ARB, they are here, and ACE inhibitor, they are here. You have to imagine that this forest plot is comparing each one against placebo, and in this case is death, but the information is not only taken from the study comparing that drug with placebo, but is taken from that study against all the others, and placebo is sort of pooled all together. So the effects can be compared one with the other. Fewer deaths with the active drug on this side, so whatever is on the left of the line is good, whatever is on the right is bad. And you see that ARB and ACE inhibitor are more or less in the same place. So not really any difference. The best seems to be obtained by adding a calcium channel blocker to ACE inhibitors. That was mortality. End-stage kidney disease, again, ACE and ARB. Actually, ACE seems to be a bit better. There's more variability, but there's not difference. I would not prefer to use ARB based on this one here. Then they go on, acute kidney injury. You know that this drug, they can give acute renal insufficiency. ACE and ARB, non-significant effect, but in case they give acute harm, more or less with the same likelihood. Doubling serum creatinine. How would you call this kind of outcome? One. Can't hear, or you, so is a hard outcome. Mortality is a hard outcome, okay? Which kind of outcome is this one? I think you know. Surrogate. Why would you study creatinine instead of mortality? Are you more interested in saving the life of your patient or keeping their creatinine low? Sorry? Saving the life of the patient. So are you interested in creatinine at all or not? Yes. Do you measure creatinine in diabetic patient on ACE inhibitor treatment? Yes. Why you measure it? Well, not because you have nothing else to do, I guess, right? So there's a reason why you measure it. Okay, so she is on the right path, and she says, well, I'm not only interested in keeping them alive, I want them to be well. So what is the difference in the well-being of the patient if his creatinine is 70 or 120? Is an indicator of mortality. So he still does well when he's at 120, but he will die earlier or later, I don't know. Or maybe is not really predicting mortality, but are you suggesting that someone with 120 of creatinine will be sooner in renal insufficiency? No. Might, but I'm not so sure. 70, 120. Maybe if the creatinine is 300 consistently over time, well, won't you see that patient more often? Won't you reduce the dose of ACE inhibitor? Possibly yes, or would you completely hold the ACE inhibitor in such a patient? So we look at surrogate outcome because we assume there is a correlation with some hard outcome. That's the only reason why. And that correlation is strong for some surrogate outcome. High blood pressure, we all know that higher blood pressure is strongly correlated with higher incidence of stroke and in the end, higher mortality, higher rate of cardiovascular effect. So we don't need every time to show that by reducing blood pressure, we reduce stroke. We are happy with the intermediate outcome for the positive effect. Of course, the side effect may have nothing to do with the surrogate outcome. So the pill can be great to reduce blood pressure. Unfortunately, it causes cancer, or it causes fetal abnormalities. Thalidomide was a great medication for its indication, but caused fetal abnormalities. So in this case, serum creatinine is a possible surrogate marker for renal insufficiency, but not necessarily having a large effect here has any effect on mortality. So endothelin inhibitors, did any of you notice this drug on the previous plots? Does any of you recall if that was helping with mortality or end-stage kidney disease or anything else? No, was not on those plot, was not studied for that. So we really don't know. We know that just slow down is the best one, actually, to slow down the increase in creatinine. Do you expect it will reduce mortality? Maybe. Do you abandon using drugs where you see an effect, a proven effect on mortality for this one because it slows down increasing creatinine? Would you call all your patients, not all today, maybe over a few months, and change their ACE inhibitor to this one? Possibly not. ACE inhibitor and ARB, they are again the same. Regression of albuminuria, I don't do the entire conversation again, is a surrogate outcome, and ARB and ACE, they do cause a regression. In this case, ARB is more effective, slightly more effective, even if full overlap of confidence interval, than ACE inhibitors. So the conclusion here is that when shown against placebo, ARB is good. When compared to ACE inhibitor, is as good as. That was not the conclusion of the studies suggesting to use ARB for preventing renal insufficiency in diabetics as the first choice. Some other time, the comparator is just not the right one. Consider this meta-analysis where 8 RCTs compared second-generation neuroleptics versus 20 milligram daily of haloperidol, concluding that the new neuroleptics were better, not because they were more effective, but because they were causing less complication. Is there a neurologist in the room? No. A psychiatrist? No. Anyone has any idea what's wrong with these studies? Any of you have ever prescribed haloperidol? Yes, good. In Emerge, maybe. Or, oh, you are a psychiatrist. Good, sorry. Miss you. So what's wrong with these studies? The dosage. So usually you don't use haloperidol at above 12 milligram per day because you know that you are inducing side effect. So there's no point. If you set up a study, 8 studies were set up with a dose of comparator that was intentionally chosen to provoke side effect, to show that the new medication was better. It's sort of when you pick your opponent for a tennis match properly, you can always win or always lose, depending what you like. So again, psychiatrist on the spot. Paroxetine versus amitriptyline twice a day, less drowsiness. What's wrong here? Yeah, it's not really the dosage. It's that amitriptyline is known to provoke drowsiness, and you give it at bedtime. So if you give it in the morning, no surprise, the patient will be drowsy all day. Did you get any amitriptyline this morning, by the way? No. Okay. So you have no excuse. If you build a study that way, you will always show success. Those are the references. So always think when you read a study, is the comparator something that makes sense to me? This is what I'm using. If not, you won't adopt a treatment to change something you don't do. Surrogate endpoints. Now we'll be quick here because we have already touched upon what the surrogate endpoint is. The endothelin example is the classical one, and the same for regression of albuminuria. You don't choose your drug based just on the effect on surrogate endpoint. You want to see also hard endpoint. Now, sometimes is complicated. Look at this study. This was a study in 2006 where you know that the diabetes is very impactful on health of a population. So it would be nice to be able to prevent diabetes instead than wasting time taking care for diabetic patients. So they tried to see if rosiglitazone was effective in diabetes prevention. 5,000 patients randomized to just lifestyle, trying to prevent diabetes by eating healthy, staying on the appropriate weight, doing physical exercise, or same kind of fun, and rosiglitazone. And then they followed the patient for 3 to 5 years. Study published on Lancet. Lancet is not the preferred journal for everyone, but is quite as good as New England. So good study if you judge from the journal where it was published. Now, they had a composite primary outcome. We'll get later on to what a composite is, but they also reported all the components, which is what they should do. So they say, we made a judgment based on number of cases of diabetes prevented and death. And they said death, there's no difference, but in terms of prevention of diabetes, we got only 10% diabetes in those treated and 25% in those non-treated. So 15% reduction, absolute reduction. And that was not really the diabetes diagnosed by the physician, but the diabetes diagnosed by a lab test that was done during the study. 8% lab diagnosed diabetes against 21% in the control. So the composite outcome, the sum of effect on diabetes and non-mortality, was a reduction of 14%, where death was not increased, not decreased, and so most of the gain was reduction of diabetes. Now, if you look at cardiovascular events, they were pretty similar, slightly more, but not significantly more for rosiglitazone. In particular, there were very, very few cases of cardiac heart failure in the control group. This was a pretty young population, so you won't expect them to have CHF. There were 14 cases in rosiglitazone. Well, not an happy news, but still is 0.01, 0.5%. Would you expect this to be random? In a study of 5,000 patients, can you have this as a random effect? It's unlikely, but it's still possible. The statistics tells you that 95% of cases, this is not by chance. It's still possible, but I mean, clearly rosiglitazone has some effect on cardiac function. There are 12 patients who develop CHF. So the conclusion of the paper, I have showed you the result first. No effect on mortality, people dies the same, many less diabetes, 12 more cases in 5,000 patients of CHF. I don't know what your conclusion would be. The author concluded that 8 milligram day of rosiglitazone plus lifestyle intervention reduced diabetes by 60% relative or 14% absolute, with a number needed to treat of 7. So if you treat 7 patients for 3 years with 8 milligram of rosiglitazone, you get 1 less case of diabetes. You treat 1,000 patients, you have 144 less cases of diabetes and 5 cases of CHF. You know, 144 against 5, you may say 5, let's say they die, but you still have 141 less cases of diabetes. Now, what you imagine was the conclusion. I'm not saying, I told you already, they say these are the numbers needed to treat. But would you imagine this paper having a strong recommendation for this treatment? Or maybe a weak recommendation, only those with a family history, or only those with a history of stroke, or strong indication for all? How you would imagine the conclusion of the paper? Strong? Strong. Okay. Would you imagine they had said, leave rosiglitazone alone, don't use it for diabetes prevention? No. No one cares about those 5 patients per 1,000 dying or developing CHF? Is a sufficient price to pay? Oh, well, pharma? Okay, so you say, I expect them saying strong indication, you would not use rosiglitazone. Okay. So let's assume we discuss this with the patient, and he won't, but let's say I would, and you play the patient role, and I say, oh, you know, there's a new paper showing that we can prevent diabetes, your family has diabetes, this population, in this country, diabetes is 25% of cases. 1 in 4 develop diabetes. I have a pill that can prevent your diabetes. And so you ask me, okay, fine, let's consider what I guess by taking this pill. Well, you get less chance of developing diabetes. And then you are a patient, not a doctor, so you ask me back, what happens if I develop diabetes? What happens if you develop diabetes? You are treating diabetic patient. What happened to a diabetic patient? Right, but how long it takes to get there? Depend on the level of control. So when you have a first diagnosis, what you do? Yes. So you say, I'm sorry, now it's time for you to stop having fun. You go on a diet, you exercise. And then if they don't, they get to, okay. So, I mean, it's not that you get diabetes today and you are dead in 3 months. Oh, it takes time. There is a cure for diabetes or not? Are you sending the patient at first diagnosis of diabetes to the psychiatrist for counseling and support like deadly cancer patient or no? No, for sure there is someone else in the family who has diabetes and he says, oh, don't worry, I had diabetes for 20 years, who cares? I don't have any more the left foot, but still, continue smoking and so on. So, in the end, if you get diabetes, you have to take a drug. Now the patient is sort of confused and say, okay, so you mean if I get diabetes, you'll give me the same drug, but instead of starting now, you will start 3 years down the road if I develop diabetes? What's your answer? Would you start someone at the first day, first diagnosis of diabetes on rosiglitazone? No. Why not? Sorry? Not the recommended. But why is not the recommended? No one knows? Cost and, yeah, side effect. So you don't use it because you have safer drugs. So your answer is no, no, no. If you develop diabetes, I'm not giving you rosiglitazone. That's not good for you. I'll give you something else. So the patient says, okay, so you want to give me a drug to prevent a disease, and if I develop that disease, you give me a better drug? So what? Are you really had a bad day or what? So I agree with the colleague. We won't consider doing it. But people started doing it. And there was need of an editorial on New England challenging the Lancet result and showing the same data in a different ways, saying, you know, you have presented, they also collected other patients from other studies, but the bottom line is how often you have the new diagnosis, what happened about anxiety, cost, monitoring, and so on. So no mention in the trial of what happened to patients because they were taking a drug and fearing to get diabetes. And then the bottom line is that the only striking effect is the increase of heart failure, because the effect on reduction of diagnosis and the rest is very, very minimal. So the only thing you do if you adopt this treatment is to increase by a little bit, but sizable little bit, the chance of having CHF. So would you use it? You don't. Good. But if you had misread the paper, you would have prescribed it. And what was wrong? Was wrong associating a non-important endpoint like diagnosing diabetes against a significant endpoint, which is developing CHF. Even if only 5 patients developed CHF, those were in trouble. The 144, large number, who didn't get diabetes, what's the problem? If they had gotten diabetes, they would have just been started on rosiglitazone. And the other 920, they would have been happily playing around on no medication. A lot of money saved and so on. So surrogate endpoint, diagnosis of diabetes is not a surrogate for survival or quality of life. All the medication that we use for Alzheimer, they are tested on cognitive function. They have an effect on solving quizzes, which is not saying is bad to be able to solve a quiz. And our colleagues in psychiatry, they make a great deal of answering quiz correctly. But what counts in the end is function and behavior. If you solve quiz better, but you mess up the house every day, I'm not sure if you are happier and your family is happier for you to take that medication that makes you solve quizzes. Unfortunately, that's not what you do most of your time. You just get lost around and you go searching for quizzes to solve, but you don't come back home for dinner. Bone density instead that fractures. We are happy to know that our BMD, our trabecular structure at MRI, and our densitometry are improved. But what really cares is, will we have a fracture? Oxygenation, oxygen level. You know, I don't know if here is like in Canada. In Canada, your oxygen level drives where you sit in the ward. You can be in a standard bed, in a step-down unit, and then you go to ICU. Depending how you respond to oxygen, no matter if the one on the bed besides you has a normal oxygen, unfortunately is unable to speak and he doesn't understand what's going on, you can easily comment on the book you are reading. You don't need to stop talking, but your oxygen is 2 millimeters lower than it should. You go to ICU and they intubate you. So I'm not saying that that's wrong. We have to manage patient and we have rules, fine, but I would like not to be terminated just because I don't show well on the oximeter. There are other functions that are more important. You have to show me that the oxygen correlates with mortality. Asymptomatic DVT, we had yesterday the ARM paper on those DVT that are picked at ultrasound and not clinically relevant. Do they matter? We don't know. And so on. So beware of surrogate endpoint. Ask you, is this endpoint something I would spend time after? Composite endpoints is easier when you understand that not all endpoints are the same. How would you like to see a composite endpoint? Would you see, for example, would you like a study like this, showing that, again, a sartan compared to a calcium channel blocker gives you a improvement in terms of a combined count of all-cause mortality, progression to end-stage renal disease, and doubling of serum creatinine. And it produces a relative risk reduction of 20%. Are you happy? Would you be satisfied enough with this presentation to say, I'll prefer irbesartan to amlodipine? No. What's wrong here? Right. So you don't want to count together mortality, end-stage renal disease, and serum creatinine. And why you don't want to count them together? Right. It can even mask something wrong. You always need to go and check the individual item. Can you tell out of these slides that irbesartan reduces mortality? You cannot. But if you look at the three, so the composite endpoint is 20%. Now let's look at what happened on creatinine. It's reduced by 33%. That's good. End-stage renal disease reduced by 23%. Well, that's good as well. She was measuring creatinine because convinced that it would have predicted renal function over time. And it does. Those that do better here, they also do better here. Unfortunately, mortality is on the other side. So they die more. They have better creatinine, they progress less to end-stage renal failure. Unfortunately, some of them, they don't make it at all to renal failure. They die before, but the composite is positive. That's why, one, you shouldn't be pooling surrogate with ARD. These two alone, they would have given a non-significant effect. As soon as you add this one, it becomes significant. That's how you can manipulate a clinical trial to make it tell what you want. Again, this was a pharma-sponsored study. And the problem is the outcomes are of different importance, and the biggest effect is on the least important of the three. So ideally, you use a composite endpoint by pooling together endpoint of the same relevance. Again, when you have composite endpoint, take the time of going and looking into the single component. Try stopped early. Who knows a good reason to stop a trial early? Right, so when you realize that you are killing people, you are treating people and they die more than you would have expected. The trial is blind, so you don't really know if they are dying in the placebo group or in the treatment group. What you know is that you expected an overall mortality of some sort, and the mortality is higher and is all in one group. Whatever it is no good. You stop the trial. Fine. Another good reason to stop a trial? Excellent results. So it goes so well that you start thinking, this treatment is so good that I really feel bad not giving it to everyone. I don't like giving it only to one group. Is this different from increased mortality, or is the same? From the ethical viewpoint, is it the same, stopping a trial because people is dying more than expected, or there is a wide difference in mortality between the two groups because you are saving life on one? Ethically, you see a big difference? It's the same. Honestly, I think it's the same. If Gord Guyot was here in my place, he would say it's different. I ask him every time. I don't understand why it's different. And I know many more people that think that it's the same. You shouldn't stop in one case like you don't stop in the other, or vice versa. You can't really tell if saving events or causing deaths is different until you unblind the trial. There's another cause why you would stop a trial early. Sorry? You run out of money. Okay, but well, that's fine, but you should have thought of that before. It's not what you did do with the money. You had the money on the side when you started the trial. It's close, you are close, but it's not because you don't have money. It's because non-efficacy. So you still have the money, but you were expecting a difference. And after, I say, you plan to enroll 10,000 patients, after 1,000 patients, you were expecting seeing some difference, not significant, too few, but some difference. If there's zero difference, you try to say, okay, let's assume we go on this way. What happened? No way of showing a difference. And then you say, okay, let's try 1,000 more patients. 2,000 patients, still no difference. Then you do the math, and your accountant tells you, listen, there's no way we will show a difference later on. Why don't we stop this trial and use the money to do somewhere else, something else better? So he's stopping early for futility. It doesn't matter continuing, there is no difference. So it's an economical reason, but it's futility. Good. These are the three main reasons. Now, there has been a lot of discussion in the community around trials stopped early for efficacy. I have to say that is a problem, and the problem is that pharma often stop a trial early when there is an effect. I don't think that ethically is different. You should do the same when it's for mortality. No one complains on mortality because you don't sell that drug. So the only real difference is that if you stop for mortality, you stop something. It might be that that mortality was transient and later on there was an effect, but you can't afford those life lost. And you won't anyways use the treatment. For effect, it is stopped because you take the right moment to stop it. I'll show you a different example, and then we'll go to what usually happens. This treatment, adding one course of chemotherapy for AML was proposed in 1997, showing a significant effect. It's here. Then, as usually happens in oncology, you use the treatment, but you continue doing trials. And this effect was confirmed, but was decreasing. And they said, why it comes out smaller than before? Some of these trials were actually going in parallel, and then continuing enough, they showed that indeed that treatment was not doing well. And the reason is, and here you see it through different trials, but if you imagine a large trial, you could have shown effect first and then not later. Imagine that this is the no effect line and this is the true effect of treatment. Usually what happens, if you measure that effect every other week, you will see something like this. So sometimes it's higher, sometimes it's lower, and then it lands somewhere. So there are variations, and if you were to stop the trial, you will see a different effect. Some other time, you have initially no effect. Actually, it seems that it's doing worse, and then it catch up and get there. If you were to do an analysis here for safety, you might have stopped this trial. Okay? But you don't. I'm convinced we should, but we don't. No one complains about this, and you end with the effect. What happens if you have instead a very lucky trial where initially you have a big effect and then you go down? If you had set rules to stop the trial for efficacy, and this was the striking effect the colleague was referring to before, you would stop the trial at any of these points, and you would say this treatment works, and works very well. Indeed, if you had continued, you would have seen a much lower effect. So you need to know that trial stopped early shouldn't be used until they are confirmed, at least by a second trial. Confounding, where we are with time. When are we supposed to end? I'm confused now. Is 10:30 or 11? 11. So I still have time to go over this, and still we'll get 5 or 15 maybe minutes of fresh air. Fresh, I don't know, but air. Okay, so
We're good at time.
we are good? Good. Okay. So let's go again over confounding in observational trials. Who of you is a surgeon? Yesterday there was a surgeon, was here. Good. So, and maybe there are also internists or anesthesiologists that help, or another surgeon is there, that helps with perioperative medicine. So there are a lot of surgeries going on every year, and surgery, for the good or the bad, impacts on mortality. Surgery saves lives, clearly. There are diseases that are deadly if there is no surgeon that helps you. But if you look at elective surgeries like hip or knee replacement or plastic surgery, there is a sizable mortality around surgery, which is in the 1, 2, 3, 4, depending on your class of risk %. And is a risk that is there. And you take it and you say, well, I might die today in OR, but if I don't, then I can freely walk. I don't have any more this nasty pain in my hip. It's absolutely patient preferences and values. But you cannot ignore that there is some mortality related to surgery. And there are other surgeries where you cannot avoid the surgery, you cannot avoid repairing a perforation of the bowel or perforation of the stomach, or there are many other oncological surgeries that are needed, still they have some associated risk of mortality. It's a form of stress. Can you name any medication that reduces perioperative mortality? The first way to reduce your mortality is choose the right surgeon and the right anesthesiologist. But after you have done that and you have maximized your chance of survival, then is there any medication that will help you survive a surgery? Come on. Beta blockers. No, what? Prophylactic antibiotics. Okay. What? Beta blockers. Why beta blockers? Prophylactic antibiotics, they may, is there any infective disease specialist around? Or infection control specialist or public health? No. It might, it's not clear if you generate more resistance, and yeah, you may save some wound infection, but you can have some C. diff, diarrhea, and some other selection of really bad bugs, and you do better, but someone else dies. So it's not really used over the border. It's used in specific surgeries, septic surgeries for sure. Dental surgery, that's what we will discuss in the next tutorial. But I wouldn't say that everyone undergoing surgery gets antibiotics with proof that it works. One shot of 2 grams of beta-lactam, I think everyone gets. Is that proven? I'm not sure. It might. It's not my field. But beta blockers, why beta blockers? Well, because non-cardiac surgery increases levels of catecholamines, and so you have increase in heart rate, blood pressure, free fatty acid, oxygen demand, blah, blah, blah. Beta blockers can slow all of this down. And indeed, in 1999, again on New England, Yasemin is happy, they published a study on New England where in elective vascular surgery, and they were monitoring patients with, so it was not a mortality study initially, they were showing the effect on the echo. They initially planned to show that beta blockers were reducing cardiac stress, and they did these unblinded studies where the primary endpoint became, after they showed the effect, deaths and non-fatal myocardial infarction, non-fatal myocardial infarction. They planned to enroll 266 patients, and after 100 patients applying a safety stopping rule, they stopped, because after 112, there were 2 deaths in those on beta blockers and 18 deaths in those on placebo. So 10 times more death. Wow, this works. And they stopped. You almost never see relative risk reduction of that range, 91% reduction in mortality. I would have stopped. Now, there were other studies around. So in 2000, they did a meta-analysis. Polderman's is here, and this was the first one significant. There were 3, 1 negative, 2 positive, non-significant, Polderman. Then immediately, others tried to confirm, they got positive result. Actually, these studies were stopped. These other studies were stopped as well, and overall, an effect. Now, there is not a lot of heterogeneity. We will discuss later on what heterogeneity is. So 40%, one might have said, okay, yeah, they are a bit all over the place, but most of them, they show an effect. I'm happy. Let's use beta blocker forever. Someone, maybe just to try to explain why there was variability, or maybe to get an extra paper published in New England, by the way, they did a study showing that depending on your risk score, beta blocker, they were helping or not. So if you were not at risk, not that good. But if you were at risk, yes. Well, it makes sense. You don't use it for everyone, but you use it when it's indicated. And then they did other analyses. Is it working in those with hypertension, diabetes? It was clearly correlated with the risk of mortality, intra-op mortality. Now, my colleague P.J. Devereaux at the Population Health Research Institute at McMaster, where Salim Yusuf worked, said, okay, I don't think we can treat millions of patients just on a meta-analysis. There was no single large study showing this effect. And I recall when he was designing the study, he was really, he was looking at his own promotion. He was willing to have a paper on New England. And he said, well, this is an easy go. I need 5,000 patients. Actually, he ended for 9,000 patients, but that's doable. And he says this will be the first single study showing that beta blockers do protect. This will be a landmark paper, New England, and good for me and good for everyone. It won't show anything new, but will confirm in a single study. Now, primary outcome, composite, but deaths, non-fatal myocardial infarction, and non-fatal cardiovascular accident, including everything. So again, all strong outcome. There was a gain, not huge, but 6.9% to 5.9, one less death in 100 patients. Non-fatal MI, significant reduction. Cardiovascular deaths, no reduction, but this is an acceptable random difference, not significant. So, okay, all seems good. And if you look at the non-fatal, again, no difference. So, white is placebo, red is beta blocker, this is mortality, you want to stay low. On beta blocker, you are lower than placebo for composite primary, for non-fatal MI. So you do better for both. That's good. Secondary outcomes in the study were total mortality. Total mortality, and this was a surprise, was higher. In all the previous studies, Perlman and the others, there was no effect on total mortality. Cardiovascular mortality was better. Then surviving or not, that was left to the surgeon. But there was no effect, no beta blocker difference. Here you start seeing, yes, 1% less cardiovascular mortality, but overall mortality goes up by 1. What's happening here? And again, this is mortality. Placebo is white. Lower is better. If your goal is not dying of myocardial infarction, but if your goal is not dying no matter what the cause is, I want to stay alive, I'm not really happy being dead for a different reason than cardiovascular, then you prefer to be on placebo. Placebo is better here. Now, what would you do? Well, would you start looking at the causes of death, right? Cardiovascular mortality is better, but overall mortality is worse. I want to know why people is dying. And people is dying cardiogenic shock or CHF? No. Non-cardiovascular death. Sepsis or infection. Wow. People is dying of sepsis. So she was right. We need to give antibiotics because that's what kills people, not beta blockers. We could have saved all of this if we were listening to you. Okay, we need to invite you at MAC next time. So, actually, when PJ saw this result, he went back to the literature because he was expecting that this was the cause, but really there is no difference here. That was expected by mechanism. How to explain sepsis or infection? And going back to one of the previous systematic reviews and studies, there was evidence that those in metoprolol, they had less reinfarction, less ventricular fibrillation, but the effect was counterbalanced by cardiogenic shock. So this is what he was expecting, cardiogenic shock. But is not what the POISE study showed. How can you link cardiogenic shock with infection? What do you think? Septic emboli. Yeah, it's possible. But really, the link was stroke. You know, stroke, depending on the setting, depending on the center, to get 9,000 patients, PJ had to enroll centers all over the world. And when you have a stroke, you can have a shock, cardiogenic shock, depending on where the stroke is. Or you can have an infection as a complication of intubation, ab ingestis, and so on. Now, stroke was clearly increased in the POISE study, 20 more cases of stroke. And again, placebo is much better than treatment, lower on this stroke stroke curve. So if we try to put all of this together, there is an effect on non-fatal MI. And if we start compiling a table, when you have to decide in presence of diverging effects, so you have a gain on one side, arm on the other, you have to come up with a summary structure. We will look at summary tables speaking of guidelines, but I'll start filling one up for you. So you put the outcome here, myocardial infarction, how many participants? 10,000, and then you have your assessment of risk of bias, good study, consistency across many studies, directness, yes, this patient was a pragmatic studies, everyone went in, no limitation, no publication bias, so high quality of evidence, clear effect on mortality. We reduce the 1.5% the rate of myocardial infarction. Mortality goes against. Now for mortality, 10,000 patients again, some studies showed the effect, some didn't, so there is some inconsistency. There were few deaths, so it's not so precise, the estimate. We are a bit less confident on the effect on mortality, but still, if the effect is there, will be 1.2%, so 20% increase, which means 1 every 200 more will die. Then if you add stroke, this is the meta-analysis of the different studies, this is the effect on stroke, you have 10,000 patients, all good, high quality of evidence, doubling of the rate of stroke. You have 20 in the placebo, 40 in the treated group in POISE. If you look at the entire studies, you have 60. Again, you have about 10 more. So you get to 70, 75 stroke at all divided between the two arms. So we are quite confident there is an effect. So what would you do? Would you use beta blockers in surgery or not? And would you make a recommendation for everyone or for someone? The effect is there, mortality is reduced, cardiovascular events are reduced, but you induce stroke. So maybe you have to select your population based on the risk factor, and maybe this is the reason why in the original studies, patients at high risk, they got a gain because their risk of stroke was low, their cardiovascular risk was high. While if you look at low-risk patients, their risk of having a cardiovascular event was low, and then stroke start being the only thing you see in this patient. You cause one stroke here, one stroke there. So a conditional recommendation. Beta blockers are currently used only in high-risk patients without previous stroke events. There is plenty of other studies where initially we thought that putting a bypass, diverting the liquor from intra to extracranial was saving in case of intracranial masses, but indeed when tested in an RCT showed an increase, or hormone replacement therapy for postmenopausal women, the healthy survivor bias. It seems to prevent cardiovascular disease. When you do then a randomized trial, it increases the risk of cardiovascular events. Or vitamin E in core study was associated with a decrease in cardiovascular death. Then when you do a proper study, you show no effect. So whenever a study is possible, unless it is unethical, unless it's a risk factor, unless you will not get the money to randomize enough patients, but if you can, you use the cohort study to generate hypotheses, and then you test the hypothesis in RCTs. And this has been shown in a Cochrane reviews, where most of the problem is that observational studies, they have a bias in terms of the two groups not being at the same risk, but they have the gain of having a real-world population. The population is more similar to the one you use. So there are reasons to use RCTs to prove the hypothesis, but then the moment you go to apply the result of the RCTs, what you have learned in the cohort study comes back useful, because the baseline risk can be different. And this is what has been shown in this Cochrane review. Now, looking to something from far doesn't necessarily show you the entire picture. That's why you need the randomized trial, and that's why you need to carefully read the literature. I think we made the point of checking trials stopped early, and ideally wait for a second trial before adopting a treatment. The main problem with trials stopped early is that usually, like it happened for the one on beta blockers, once one is stopped, all the others are stopped, and there is no more research going on in that field. It's so striking effect, no one is willing to be randomized anymore. Beware of what's published in high impact journal. Read New England if you like, but don't take the guard down. You can be kicked and be caught unprepared. Expert recommendation may not be good. Composite endpoints always worry. Check for the individual component. Physiology, like the case of beta blockers, sometimes it helps, sometimes it doesn't. We always focus on some mechanism, we forget some other mechanism. Beta blockers, they lower the pressure, you can have a stroke. Observational studies, they help a lot, but they have their own limitation. And finally, and that's what we will be spending some time tomorrow, is even when you are sure that you get it right about what happened in terms of benefit and what happened in terms of risk, that's where the researcher stops. And as a researcher, someone tells you, listen, I did the best I could, I did my own trial, then I did a systematic review, this is the effect on mortality, this is the effect on stroke, this is the total effect, now it's up to you. You take these to your next patient and you decide how you go. There's no solution in the data. There are then to call in those components we discussed yesterday, cost, patient preferences and values, and so on. So balancing benefit and risk remains an open problem and remains what we want to focus on after we are sure that we have read the literature correctly. Thank you.
Well, thank you. Perfect timing. So I had three coffees today. Yasmin, I don't know if I decided just to keep this with me for the rest of the day. I'm not 50, but I don't know if that's going to work. That hasn't been studied yet, right? But I guess I took a home message to have a little bit of coffee. So for the rest of the day, sorry, guys, that I'm keeping that with me. Just to remind me of a couple of housekeeping issues, I hope that you got a tablet or a laptop with you. Everyone has it, so you can read the papers if you haven't printed the papers yet. And also, we need really a transparent evaluation. I've done an honest mistake by missing one of the names on the evaluations, a huge apology for Dr. Adnan Lugayan missing his name. So if you're attending the small group the small group tutorial with Dr. Adnan Lugayan, please write his name on the evaluation and then check which tutorial. I hope it wasn't confusing how you select the presenter or the facilitator and the small or large group presenter or lecture. And again, you're probably now you're aware of the attendance, how we take attendance. If you have any questions, you can ask the organizers in here, ask me in particular. I'm happy to answer questions. And tomorrow, inshallah, we're going to have a group photo. That's going to be probably just before the first small group tutorial. So after the second lecture, we're all going to be on stage and take that group photo. No one is exempted from that group photo. All of you will be on the stage to take a group photo. That's good for record for us and also a nice memory. Now we're going to break down into small groups, right time, and each one of you will go back to your group, and we look forward for